Good morning, folks. Thank you for joining us. We're going to give one more minute before we get started. Right. Hello, folks, and good morning. Just looking to see how many folks that we have that's still joining us. All right. Maybe we'll give it another 30 seconds. All right. I think we'll get going. Just wanted to make sure we have enough time, an opportunity for folks to present, and also for you to participate and ask questions. So, good morning, everybody. My name is Boris Vilgorin. I'm the healthcare strategy officer here at MCTAC. I'm joined by a number of my colleagues from MCTAC, but I'm also very excited to have our friends and colleagues from CCSI joining and presenting on the mental health outpatient treatment and rehabilitative services, also known as MOTORS. I know folks have many different ways of pronouncing it, but we're going to probably refer to it as clinic going forward, but specifically focusing on the fiscal model today. Today's presentation is being recorded, just wanted to make sure, and both the recording and the slides will be made available. We do encourage folks, as always, to use the chat box to communicate with us if you have any comments, questions, and so forth. We do put aside some time at the end for that, but also we'll be taking those questions throughout the presentation. Just one additional, or excuse me, couple of additional pieces to just highlight today's presentation. As I've mentioned, today's presentation is going to focus on the fiscal model that was put together by CCSI. So both the model will be reviewed and a companion guide that comes with it. We will not be covering any specific questions around billing or implementation of any clinic services or any questions of that nature. So please, to the best ability, if you can direct the questions on the topic and the subject we're going to be discussing, again, today's model and the companion guide. And we hope that you will find this useful. I also wanted the other piece to mention, as many of you might know and probably have been using, we at MCTAC, again, together with CCSI, have a fiscal model. They've been around, David, probably for over 10 years now. That was specific to the clinic. That was put together, I think, around the time of APG's implementation and clinic transitioning at that time. And of course, we all know the amount of changes that occurred over this period in clinics, especially recently with peer services, offsite, and a number of other different changes that have happened. So with all of those changes in place, we once again reached out to our colleagues at CCSI to help us update and create new financial modeling tool. And so when this goes live, and we hope after today's presentation in another week or two max, we'll be taking the old fiscal modeling tool down, replacing it with this one because we want to make sure you have the latest version. And with that, I will turn this over to David, who will introduce himself and will take us through the presentation.
Thank you, Boris, and good morning, everybody. It's a pleasure to be here with you this morning. And as Boris said, we're going to be doing two things this morning. One is we're going to be introducing an Excel-based fiscal model for which we'll be replacing the model that is currently posted on the MCTAC website. And the fiscal model, we're going to review the tool and purpose, data that's needed to use it, information that might be generated, and how the tool can support your financial stability. Also, my colleague Chris Copeland is going to be going through a companion guide to review and discuss best practices in using the tool to complement your modeling and scenario building. Quick introductions. As I said, I'm David Warsnick. I'm Senior Director of Fiscal Performance Improvement at CCSI, and I've been working in this not-for-profit behavioral health space for more years than I like to remember. We'll be joined by my colleague, Chris Copeland. Chris, you want to introduce yourself real quick?
Sure. I work closely with David at CCSI, actually senior director, but never mind, consulting services at CCSI. And again, like David, I have too many years in this work, over 40 years. But I think that the important thing about the teaming of me and David is that the model is a fiscal model, but relies on a lot of programmatic input. And I think that David and I working together on this is a reflection of how hopefully you'll be able to work internally within your agencies to gather the information and fiscal model. So look forward to David's introduction, work through this, and I'll be back with you in a little while with a companion guide.
All right. Thank you, Chris. For those who don't know CCSI, we support organizations that understand, implement, and sustain practices. We have a long-standing partnership with MCTAC and provide some support across New York State. And in this case, we're focusing specifically on a fiscal model. So it's a fiscal model. Well, it's really it's an Excel-based tool. It can be used in a number of different ways. It can be used if you're building out a new program, if you're looking to put a satellite up, if you want to understand from a fiscal standpoint how some of the changes in the regulations might affect your bottom line for your programs. It can be used that way. And I'll go through a couple of those things. We don't have a lot of time today, so we're going to do a relatively quick overview. I think that one of the reasons we provide a companion guide is that gives you very detailed understanding of the tool's suggestions of how to use it, where you're going to find the data, use it. So this today is really just a quick overview. One of the things that I think I will be talking about as we move forward is the tool can be really used as a communication tool. I think that it's very important for clinic directors, supervisors, staff to understand the underpinnings of the fiscal model. I always thought that it was important to be able to communicate to supervisors, to staff, to help them understand why we ask them to do the things we ask them to do, particularly around productivity. And so this can be used to give folks a framework, a context to better understand some of the expectations that we have from both the clinical level and from the operational level. So let's take a quick look. Let's dive right in. I'm going to bring this up. Chris, you can nod your head if you see the model. Okay. I'm going to move this so I can let me get rid of this up here and make this a little bit bigger. Okay. General overview. The tool is Excel-based. It has 4 tabs along the bottom. The primary convention in this is this color and it's going to show different. It's blue for me, are calculated fields. The yellow are input fields. For the model to work, you will need to have information in all the input fields. The calculated fields are not protected. I do that because advanced users have an opportunity to make changes if they want to, but the casual user should absolutely assure that they are not hard coding any numbers into a calculated field. It's very simple to see into calculated field. You'll see the calculation in the bar up here. In a field that's input, you won't see a calculation. If you go ahead and start inputting, hard coding your calculated fields, and you don't take care to do that, your model is going to be invalidated. That's just a word of warning. Okay, so let's start with the different tabs. I would suggest that we start here. Well, because the model is going to focus in 4 primary areas. It's going to focus in on service mix, which you're seeing right here. So why do we talk about service mix? Well, we talk about service mix because each of your services are paid at differential rates. If you're familiar, particularly in Medicaid, your APG rates, each of your service has a weight. That weight is multiplied by a base rate, and that determines the amount that you're going to be paid. It's important to understand what your service mix is from a financial standpoint, but it's also important to understand your service mix from a clinical standpoint. So as we think about the model, particularly if you're using it for scenario building or for planning or for communication and a better understanding, it is critical that you work the model with the input from both clinical leadership and financial leadership. Understanding service mix from a clinical standpoint is not the responsibility of your finance team. It is the responsibility of your clinical leadership team. So we're starting right from the beginning with input from your clinical team. Now, if you have experience in a clinic and you're working against a specific clinic, this information is relatively simple in most cases to gain from your billing system. What I do when I work with clients around understanding service mix, we have them export an Excel file with over a certain period of time with services and their CPT code. I can then create a table. I can pivot against that table. And in pivot tables, you can generate a percentage very easily. So I would suggest if you're already working and you have clinics, you go in and you run your service mix. And as you see here, calculate the percentages and put them in here. So we're starting with what you believe what either your service mix is or what you're planning it to be. And you'll see how this ties in as we go forward. So this is simple. You have these percentages of services. Here are all the Medicaid billable services and CPT codes. These are directly taken from OMH's revenue calculator. I've slightly modified the revenue calculator to be able to support not only looking at Medicaid revenue, but also looking at third-party, self-pay, Medicare, and your no pays and denial. So the next piece that you're going to be putting in is your payer mix. So this is the percentage of services that are provided by these categories. So again, it can be relatively easy to gather that data. In that export that I talked about before with your services CPT codes, who provided it, it's very easy to add in the payer. And so you might have to classify your payers, Medicaid fee-for-service, Medicaid managed care, where you take that same set of data and you can use that to better understand what your payer mix is. Payer mix is a critical factor. When we take a look at clinics, if a clinic has 80% Medicaid participation, versus a clinic that has 50% Medicaid participation, or a clinic that has a much higher Medicare, or has a high no-show, or a high denial rate, the payer mix can have a significant and huge impact. Now you'll see I've added no pay denials. I will guarantee you every single one of your clinic will provide services that you won't get paid for. So by failing to understand that there is a percentage of your services that aren't going to get paid, in the modeling, you will be overestimating your revenue. So we're going to next, after we've taken a look and taken our unit distribution, we're going to take our service mix, our payer mix, and load it in here as a percentage. And then you're going to need to load in your base rates. So here's the base rates. Again, this is right from the OMH's revenue calculator. Here's your base rate. If you are a county Article 31, your Medicaid base rate is going to be $228.61, downstate $189.23. And under the APG system, what happens is Medicaid's going to take the weight, they're going to multiply it by the base rate, and that's what you're going to be paid for the services. Now, the OMH Medicaid revenue calculator only calculates out Medicaid rates. I've added an adjustment here to be able to look at total units of service, and I'll show you how those get generated. And so what happens is we're going to take total units, and then we're going to distribute. We're going to estimate the Medicaid revenue based upon this mix. So in this case, we have 76% Medicaid. What the calculator is going to do is going to take the total contacts that you've estimated for self-help peer services. It's going to multiply it by the 76%. It's going to load this into the calculator, and the calculator is going to then calculate the Medicaid revenue for that service. One of the reasons that I included the revenue calculator, which is really a more detailed understanding of revenue at the service level, is because we've seen some significant changes over time and recently in this payment adjustment field. So there's a new modifier with a 35% enhancement for services for using an outside resource for translation. There are off-site enhancements now where your ability to provide services off-site has been expanded. That's a 50% enhancement. We have a 25% enhancement on school-based services. So these are not insignificant enhancements to your revenue generation for your Medicaid services. And so I wanted to allow an ability for you to be able to better understand how these payment adjustments, how these modifiers are going to enhance your revenue generation. And also ask yourself the question, when you go through the tool, are we fully leveraging our modifiers? And are we failing to collect data that allows us to use these enhancements? Are our billing systems configured correctly to be able to do that? And so as an example here is that I have, well, let's take this example. So I just threw this in here. Again, I just made up all these numbers. So let's say you have a school-based clinic, and your school-based clinic over here under normal circumstances is going to bill Medicaid down here $494,000. Well, with the school-based enhancement, this is going to add another $125,000 to your revenue generation by using this enhancement. And offsite enhancements, 50%. These are not insignificant. So you need to take care to be able to fully leverage these enhancements. And as you begin your planning or scenario building, make sure that you are including those in your revenue calculations, because they can be significant. You'll see up here a modification error. What happens here is if you put in more more enhancements number than actual Medicaid number, you'll see we've calculated for your psychotherapy individual 30 minutes, 1,632 contacts. If you try to calculate enhancements for 2,000 of those, you're going to get an error here. And so you know that you need to go back and fix that. The other thing that I failed to mention in the unit analysis, you'll see that I put conditional formatting in to help you make sure that this equals 100%. If it's 101, you're going to get an error. Well, it's not an error message, but that's going to turn red. If it's actually 100%, that'll turn green. So we've got our units. We have our payer mix. We have our base rate. And now we have either our actual modifiers, expected modifiers, and this will help us then calculate our Medicaid revenue. So the next piece we're going to talk about is what is called the expense calculator and summary.
David, can I just jump
Sure.
in just with a question, the strategic question, I guess.
Mhm.
Would you recommend, because it looks like this is probably better to do it on a clinic by clinic or satellite,
Yes.
rather like agency wide, right? Because we know
Yeah.
some providers have 5 clinics, 2 satellites, or 10 satellites, one, like, so there's all these combinations. And, just wanted to ask your opinion. I think this, to me, seems like more of a take one clinic at a time,
Right.
one satellite even at a time,
Yeah.
and do that in that way.
Absolutely. Yeah, I agree with you 100%. I think that in a lot of cases, if you've seen one clinic, you've seen one clinic.
Mhm.
And what I find when I work with organizations with multiple clinics, they all have different structural elements to it. They have different service mixes, they have different payer mixes, and they have different cost structures. Your rent for one place is very different from your rent for another place. You may have utilities in your lease and not. So I agree with you 100%. Understanding each of your clinics and satellite as an individual basis. So you may have a clinic that's doing really well. That's so fine. Put that over the side. It's doing very well. If you have a clinic that's doing poorly financially, then pull the tool out and use this to better what I call a variance analysis. Why is this clinic operating differentially from this clinic over here, or differentially from what we're expecting? And then we could use this tool to better understand the drivers. And the drivers are your service mix, your payer mix, your productivity, and your cost structure.
Excellent.
So yes, absolutely. It's more work. I understand that. The clinics you're happy with, put them aside for right now. The clinics that you think need more attention, you can use this tool to help support understanding, communication, and changes that you may want to put in place and benchmarks that you need to achieve. So moving here quickly, we have an ability to put in staff type. You can put individual staff in. I normally do staff type. You have an average annual salary for this position. One of the important things to consider, these models are based upon averages. So there is a level of imperfection in them. To break this down, you could break this down at a person level, and that would be fine. It's an additional level of work. If we're going to use this for scenario building, if we're going to use this for planning, if we're going to use this for budgeting, working against averages is an appropriate way of going forward. So let's take a look at this example. I have a peer. My peer's average annual salary is $42,500. And in this case, I have one. Direct care clinical staff, I have 4 FTEs. So an FTE is not a warm body. The FTE is related to the number of hours that you're paying the staff. If you have a 35-hour work week and you pay 1,820 hours a year, that 1,820 hours is the equivalent of an FTE. I break down direct care versus indirect care because it's important, I think, to understand the relationship between your direct care services. These are the folks that are providing the revenue for you, and versus the indirect care. So from a cost structure standpoint, what is the relationship between indirect care and direct care? Are we really are we controlling our indirect salary cost and really maximizing the revenue generation from our direct care? This one, contact per day, is a critical piece. Now, I've used all different kinds, and organizations used all different kinds of ways of calculating productivity. There's the old weighted average. There's APG weighted units. They're billable to paid hours. In this case, we've pivoted to contacts per day. So what this is basically saying, this peer at $4,250 a year, we expect is going to have, and now the peers are at 15-minute contacts, we expect that they're going to do 8 contacts per day. Now, they're clinical staff. The clinical staff, we have 4 of them, and on average, each clinical staff is going to provide 5.25 contacts per day. I included it at the contact level for 2 reasons. That is the way that the revenue calculator is built. It's built upon contacts. And I thought that the level of detail and understanding your Medicaid revenue, and particularly the changes in payment adjustment, was critical for understanding the changes in the regs and how that's going to impact your bottom line. So I wanted to include this calculator in there. The calculator is contact per days. And so we went over to contact per days as a measure of activity. And you'll see that this is where your unit count comes from. So if I took this out and then went to 0, you'll see that there'll be no units generated for this position. So it's important that you go through. The other reason I put in contacts per day is because it's easy for clinical staff to understand. So if you said, look, you need 5 contacts per day, 5 billable contacts per day. That's an easy concept to understand. It's an easy concept to manage. I'm not suggesting that anybody go ahead then begin changing their units, their productivity calculations. I mean, you have ingrained systems. People understand that, but from the fiscal modeling standpoint, there is an ease of use as we think about contacts per day. So each of these elements, with the exception of staff name, are critical elements that have to be put in.
Can I ask you a question, David, or a clarification point? You just mentioned around particularly the peers, you said 8 contacts. Now, peers bill in 15-minute increments. So that's 8 15-minute.
That's 8 15 minutes increment.
So if somebody saw somebody for 3/4 of an hour, that would be 3 contacts.
Right. So what you're going to say, so when we go over to the revenue calculator is going to say there's 1,768. And if you go down here, you'll see the right here, well, 1,752, 15 minutes, but it's billed out in 15-minute increments at a service weight of 0.1134. Yes, you're correct. So you have to, there's some nuances in here, and those nuances already live in your billing systems and the way that the APG weights are calculated. And, we have this combination now in Medicaid billing between APG weights from a time structure, which is different weights for 30, different weights for 45. The peers are only billed out in multiple 15-minute visits. And we have an injection only that's billed out at a fixed dollar value.
David, just because the question just came in.
Sure.
So for a number of them, they're only 15 minutes or like 30 or whatever. But when it comes for direct care clinical staff, it could be 45 or 30.
It could be 45 or 30. See, go ahead.
How does this 5.25? Does that represent 45 or 30?
This is agnostic of whether somebody is providing a 30-minute or a 40-minute or an assessment.
Right.
So we've again pivoted from the way of thinking sometimes about units. So this is 5.25. It could be 5.25 30. It could be 5.25 40. This is to align to the revenue calculator, and that's how it works. Is it the most precise way of doing it? Probably not. Does it give reasonable results? Yes, it does.
Thank you.
Okay, so let's go through the final pieces of this, because we want to some time to get to the revenue calculator. There's a couple more. So we've put in our salary costs. Now we have operational expenses. It gives you an opportunity to break them down individually. You don't have to do that, certainly, if you don't want to. I could take this and I could put a single dollar value in and take these out, and it would still be the 30 form. I put this in. Some people use this for a budgeting tool, and they like to break down their operating costs at the line item level. So let's go here, and then we'll finish up over here. So as I said before, the revenue calculator, when you put your payer mix in, the payer mix at the Medicaid level generates and calculates, you'll see here, it calculates the Medicaid revenue. We also need to calculate your other revenue sources. So what the model is going to do, it's going to generate 7,957 units. It's going to know the number of contacts that were Medicaid. It's going to generate the Medicaid revenue. It's also going to know the number of contacts that you anticipate from third party, self-pay, Medicare, and no payment. It's going to take then your payer mix calculation of contacts, and here what you need to put in is your average reimbursement rate per contact for your third-party payer or your self-pay or your Medicare, and it's going to then generate revenue for your other revenue sources. If you have a grant, third-party, other revenue sources, you can just load them in here. two final.
David, there's a little bit of a confusion. Somebody's just pointed out that 100% productivity for a direct care staff is too high. That's not what that 100% means, is it?
That is not what 100% means. That means that this person is 100% responsible for providing clinical services. Let's take a look at the supervisor. We have a clinical supervisor. The clinical supervisor carries a small caseload. So what we do is that the clinical supervisor has 20% expectation of providing clinical services. So what that means is then we're going to calculate some units for that individual person, and we're going to calculate their direct care percentage of their salary that goes to direct care. So yes, this is not related to contacts. It's related to their primary responsibility. And I know that this direct care staff does not provide clinical services 100% of the time. That's not what this is. We know that somebody's going to be working 7 hours. A day, they're going to be providing 5 contacts. The other time that they're not doing clinical work, they're going to be doing other work that is expected of them. So yes, that's an important distinction.
Thank you.
There's 2 other things that are real simple. We need to calculate fringe benefits. You put that percentage here. We need to calculate administration and overhead. You put that percentage here. And we need to calculate available to work. And that goes to this. So when we say, all right, I'm a clinical staff, I'm expected to do 5.25 contacts per day. Well, I am not, you're going to pay me for, we'll go here. You're going to pay me at a 37.5 hour work week at 1,950 hours. I am not going to be physically on site 1,950 hours because I've got holidays, I've got my vacation, I've got training days, I've got PTO. And so I'm only going to be available 1,643 hours. So when we say you want me to be there, I need 5.25 contacts per day, the model has to take into consideration that I am only going to be there, I'm only going to be there 219 days. So when it calculates my number of units, it's going to calculate it based upon the number of days I'm going to be available to provide those services. And we calculate that here. And then we take that and we put it right here, available to work, and it's going to adjust these units. And you'll see if it was 87%, your units are going to be going up because each individual will be on site more days than if their availability to work is 0.85. I know that's probably it's probably a little bit confusing to folks. Again, the way that you need to think about this is taking the companion guide, where we break out every single field and how it's used, and sit that down. And Chris, and I'm going to turn this over to Chris now, who's going to be talking about the companion guide, how it can be used and how it can answer your questions after a fairly quick run through of a model that becomes more complex because of the complexity in the interaction of the different variables that affect your financial outcome. So I'm going to stop sharing. I'm going to turn this.
Before you do that, Dave, there's a couple more questions I think are worth going through rather than jumping to the companion guide. Okay. Where would somebody put fee-for-service staff in this model from expenses?
Let me switch back to screen share. 1 second. Okay, again, real quick.
Fee for service, where the expense of fee for service staff, where would they appear in this model?
Well, your fee for service staff, what's your definition of fee for service staff that would be different from a staff that is providing services based upon your payer mix?
I guess it would be paid by service. So let's assume that
Oh, so
you
a
get
per diem.
per diem. Yeah, let's say
per
you
diem,
get 30
sorry,
bucks
yes,
per
yes.
visit, right? Versus you get $64,000 salary.
All right, so I would break that out individually. And so I would do, let's call it fee for service. And then I would put the salary that you're expected.
Right.
And
So let's say you're expecting somebody to do 1,000 contacts a year,
all right, so I
and
put
they're
their,
$30 per contact.
right,
Just
so
making all
I
these
would
numbers.
do,
You would do $30,000, right? Then
right, you put 30,000 here, you would, the FTE would be a portion. So let's see how that would work. Let's put 30,000 in here. Let's say that's let's say that's 100%. And so they need 3,000 contacts. So then we would just need to figure out what number this needs to be to get the 3,000 contacts right here. So it's a dollar value, a percentage,
but yeah, yep.
Contacts per day, and that will then, from the standpoint, is you make sure that then this says $3,000 or 3,000 units. So then you have your 3,000 units.
If you put 4 contacts, I think that'll be close enough, probably. No, in the yellow.
Oh, yeah.
Sorry.
I'm sorry. I just did the mistake that I told people not to do.
Demonstrating it, yes.
Yeah,
Right.
it's going to be
Maybe 5.
That's a lot.
No, you want to do 1,000 contacts, not 2,000.
Oh, 1,000. I'm sorry.
Yeah,
I misunderstood.
So maybe like 5.
Yeah.
5. Yeah.
You see the
All right. So that 5 will be brought over, and you'll see the revenue went up significantly.
Yep.
So yes, that's a great question. And that's how you can understand. You can even model out what your per diem staff might have as an effect on your bottom line.
Mm-hmm.
Correct.
And David, I was just going to say, there's another question around, so the deduction for the time off does not apply when you are doing per diem staff.
It does not apply because you're paying per diem staff on a contact basis in most cases. And so, yes, that would be, you would not need to take that available to work into consideration.
And there was a question about contacts per day for group psychotherapy. So again, going back to the units by percentage, it would be the number of people within the group,
right?
Would be the number of contacts.
Right. So if your goal was 5 contacts a day and you did a group of 5, you made your contacts for that day. But on day 2, you could have scheduled 6 people and 4 of them no-showed. So you didn't make your contacts for that day. So that's one of the conversations we always have around services, is the value of group services from a fiscal standpoint and from people making their productivity standpoint.
Okay.
Do you want to jump over now?
Yeah. You'll have to stop sharing and then I will share. So, second. So what we've created is a companion guide, which probably should have on the front of it, I don't know, those of you seen Hitchhiker's Guide to the Galaxies, don't panic. The complexity of the model, really, when you start using it, becomes very apparent how to use it. So what we've tried to do in terms of this guide, and I'll just scroll through it, is be very clear about what each of the tabs do. As David referenced, make sure that you're only inputting into the yellow, not the light blue. We go through the tab structure, how the tabs interrelate with each other. And then go in great detail about what each input field means. And there's 2 ways of that described in the companion guide. One is a descriptor here, and at the end of the companion guide, each of the cells is listed individually, and the definition of the cell and what data should be input into the cell is described. So what we recommend is that you would sit with the model and the companion guide side by side, and essentially what the companion guide does on paper is take you through the model in the same way that David did. So it describes the cells, what you're supposed to put in the cell, and also gives you a sense of how the cells and the tabs interrelate with each other. So for instance here, what we've done is describe the fact that it's designed to allow the contacts for each staff type. So we talked about the number of contacts that each staff type would make, drives the number of units on the units by percentage tab, and therefore the revenue on the revenue tab. So we try to outline for each of the inputs how they interrelate with each other. And it's worth becoming very sort of facile with how those interrelate, so you're able to use the financial calculator as well as possible. And then we just go through each of the cells. And I say this has been very sort of specific and detail oriented as we go through. It mentions the fact that the cells, there's an error message that arrives, and again, each of the cells, where they are and what detail to put into them. And then finally, what I also describe at the end is some ideas how to use the model, because there are going to be instances where you have an existing clinic, I think as David mentioned, that you want to look at and understand why it's performing in the way it is. So the model can be used in a way to input your existing information, your existing budget, or your existing year-to-date information into the model. And then you can begin to look at individual elements of the model to see what makes the difference. I think if you began to look at some of the overhead, it may not make a big difference to the bottom line. But if you looked at the number of services per day that individual clinician may be making, you may see a bigger impact. And so the model can be used to look at existing programs. It can be used to think about how do you grow a program, because one of the problems I think we always have is, when do you hire a new clinician? Can you bring a nurse into the clinic and be financially viable? So this model allows you to begin to do those sort of projections. What would happen if you hired an extra clinician over the year? Would the revenue grow? If they didn't see enough people, how would it affect the deficit? Or it could be that you're starting a new program entirely, so that again you'll be starting with a clean sheet. So that in that case you can begin to put in your projections and to see how that would model out. And you can use this model. It's set up to begin with to think about how you would use it over a year, but also you could use it more incrementally. You could think about prorating. So for the first 3 months of the year, we would have X amount of staff. For the next 3 months, that would grow by 2 staff, and the census would grow. So you can begin to also think about how to model growth and change for a clinic over time. And really think about doing one thing at a time. So you're not changing multiple variables, that you're thinking about, so if we change this, what happens? We change that, what happens? And I think what you'll find is that a number of smaller changes to a clinic model will make a difference, rather than thinking about one big change. And we often go at this, we've got to increase the productivity by 20%, and think about no other variables that we may be talking about. But for clinic leadership, thinking about the payer mix may be as significant and as important as thinking about the productivity, or in this case, in this model, the number of sessions per day. So hopefully using this model in a number of different ways, and again to re-emphasize the idea that most of the input into this financial model is going to come from the program staff. Knowing the number of clinic, the number of the service pattern, the staffing patterns, who you're seeing. If you're bringing a nurse on, what are they going to do? Are they going to be doing injections? Are they going to be doing health monitoring? Are they just going to be there to help the psychiatrist with the work they're doing? So all those elements of that clinic are going to be programmatic ones. So sitting finance, sitting with program staff to understand how how the financial success of a clinic is so dependent on the programmatic makeup of it is really important, and it's very instructional. I think we've found over the time that the clinic staff understanding these financial variables helps them think through how to make changes, but it also helps the finance staff to understand what the clinical staff are doing to make the results that happens on the profit and loss statements, and helps bridge that sometimes that gulf between finance and program in terms of why is this clinic losing money. Sitting down together and using this, both sides will understand that. They'll understand what it was supposed to be doing and is it performing using this model. I think one last place that this can be used is to look at the revenue that you're receiving. Does it match what you modeled? And if it doesn't, you can begin to think about, well, maybe why are we not receiving the revenue that we did? And David pointed out, maybe you're not applying the modifiers correctly. Maybe the billing system's not set up correctly. So looking at both for actual performance against projected on this model can lead to some really interesting insights as to why one clinic or all your clinics are performing in the way they are. So the companion guide hopefully is helpful in terms of the detail that you just heard from David. I'll stop sharing. The video will be available to go through again. So Dave, you can watch David again go through the clinical model, and please use this in a way that you find is going to be really helpful for both clinical and financial staff.
No, thank
So
you.
I think questions.
Yeah, no, thank you, David and Chris. So just to underscore, both the recording and the slides will be made available. They might not be this week because it's already Wednesday and takes us time to process everything, but we're definitely going to announce it when they're available. So you should be receiving that information. Again, both the recording, the Excel, the model, the companion guide, and so forth will be coming forth. I think, Chris, what you were really saying at the end, and I think David said in the beginning, don't just give this to your finance team to complete.
Yeah. No.
That would be probably the wrong thing to do, because they will complete it, but you're probably not going to be happy.
Right.
And then you won't understand why, your productivity is whatever it is, or what you have to do. So I think the team approach is, if you do anything, is to really approach this as a team, as we always say this at MCTAC, right, in regards to program people coming together with the fiscal folks. I think, as we talked about, it's important to highlight that this should be really used at a clinic level or a satellite level, meaning satellite clinic level, so you can really drill down to each clinic to see what's going on, and so forth. So I know over the years our current model has been used extensively, and I know even as last year people were still telling me on how they're using the model. So I'm hoping that with this updated version, if it's not used in the same way, that it's used even higher. And I think somebody in the chat mentioned, Chris, you kind of referred to it, and David too, you can also use it as a goal-seeking approach, right? You want to reach a particular goal.
That's the point.
You want to, right, like you said, like you can tweak things and say, look, I want to be here, whatever here means, but let me see what I need to tweak to get there. And what would that mean, right? More staff, less staff, more peers, more offsite, maybe, more modifiers, whatever it might be. But again, it's a modeling plus your strategic plan kind of approach to clinics in that way. So yeah, no, thank you. So just wanted to see, I know we got a couple of questions. We got a lot of thank yous, which I appreciate. Thank you for folks for joining as well.
Somebody's asking about technical support.
So one of the things is we, as always, you can always contact us at mctac.info. I think most of you know how to reach us. But when we send this out, we'll again let folks know how you can contact us directly if you have questions. If you're interested in some of the technical support, like I said, we work with CCSI. They do outside of MCTAC provide a lot of technical support to providers throughout New York State. So if that's the appropriate route, that's one of the possibilities. We might contact you with them. But yeah, please keep those questions coming, and we'll provide more. It's the MCTAC.info email, but we'll get that direct link. But let me just see if we covered as many questions.
Yeah, Boris, just
Yeah, go ahead. Yeah,
there's a question that came in earlier. Just wanted to just reiterate that the question is, can this tool be used for a clinic providing services to both adult and children? And so, yes, this tool is intended to be used for both of those.
Yep.
So that came in earlier. Just wanted to make sure we address that.
Yes, thank you.
I think we got all the questions,
yeah.
I think, in the end.
While you guys are looking at the chat, I mean,
Yeah,
we call it a model because it's an attempt to simplify a very complex set of variables. And one of my goals was to help people identify what are the key variables, both clinically and financially, that impact financial outcome. So at the very least, what I hope it would is help those who are responsible for monitoring for clinics for financial outcome, for clinical quality, for consistency, to understand each of the variables that are important and how they interact with each other. It's a complex set of relationships, and we try to simplify it as much as we can through this model and allow you the opportunity to do the kind of what ifs, budget building, scenario building to help you better understand and pay attention to the things that are important.
That make a big change, yeah.
The number of pencils you buy is not important. The number of contacts you have per day is important. The number, your payer mix is important. Your service mix is important. Let's focus. It's designed to have you focus on those that really have an impact.
Yeah, there's a question earlier on about the difference between 30 minutes and 45 minutes. But in terms of the unit mix, that's where that begins to be taking place. If you're sort of 50% of the time you're doing 30 minutes, 50% of the time you're doing 45 minutes, then that's going to reflect in the revenue.
That will be reflected in your
so
revenue.
That isn't lost in the detail. That's right.
It is not lost in the detail, no.
All right. I think with that, I once again want to thank our colleagues at CCSI, David and Chris, for pulling this together. Great presentation. I know folks want to know, when is it going to be available? Not only if. We got a bunch of questions on when. We're going to try to get this out next week. And of course, we're going to try to get this out as soon as possible. But by the question of when, and we got quite a few of those, I think people are eager to get their hands on, or at least that's how I'm going to interpret it. So again, thank you guys for your presentation. Thank you for everybody for joining us today and your questions. And we'll look forward to more discussions around this. All right. Thank you, everybody. Have a great rest of your day.
It's a pleasure.
Take care. Thank you.
Take
Bye-bye.
care.